Welcome to the HR on the Offensive podcast, a weekly podcast by Lace Partners, a fundamentally different HR and payroll consultancy. Each week, we tackle some of the most interesting topics facing senior HR professionals. So whether that's from employee value proposition, performance management, people strategy, or even payroll, we cover it all. So join us for the next 30 minutes. And if you like what you hear, subscribe wherever you get your podcasts. Now, on with the show. Good morning, good afternoon, and good evening, and welcome to the latest HR on the Offensive podcast. It's me, Chris Howard from Lace Partners, joining you as always on these weekly pods that we do enjoy doing. And today's one is no exception, and it's a little bit different than usual because it's a topic that it's a little bit of a taboo subject, certainly within society, but in the HR on the Offensive world, in our podcast, we do like to get the occasional topic which we can really dig into that maybe is a little bit, I was going to say controversial. It's not the word. I think taboo is probably the best way of describing it. And it's around addiction. You might be thinking, addiction? This is a HR podcast. Why is he talking about addiction? But actually, if you think about the role that addiction plays, and my guest is going to talk in a little bit more detail about that. If you think about the role that it plays in life, work is a big part of people's lives, and making the distinction between addiction and different forms of addiction and the world of work, I don't think is something that you can do. You can't tell me that there are people in the world of work that have never had an addiction of some kind, as we're going to talk about. That's certainly not the case. And also the perceptions on the types of addiction, I think, are worth exploring as well, because you have, as my guest and I talked about before we went live, you have types of addictions that perhaps people don't think about. It's not just the big sort of extremely taboo addictions like drugs or alcohol. There are other types of addiction as well. My guest is a gentleman called Georges Petitjean. He is a clinical director in drug and alcohol treatment at an organisation called Inclusion. Georges, how are you doing?
I'm very well, thank you. Thank you for having me on your show. You're a very brave person, Chris.
Well, brave, is that just because I've tried and butchered to say your name there? I tried my best sort of French Georges, but how did I get on?
Oh, you did very well. No, you are very brave because I understand your podcast is about tackling the biggest challenges in HR, and I have one for you.
Okay, so we're going to talk about that, but as we like to do on this podcast, we do a fundamentally different question. If you're listening to this for the first time, it's a little bit of fun that we like to have right at the beginning. I do appreciate this isn't the most of fun topics, but it isn't important to go through. But we do observe our tradition here on the podcast. George, my fundamentally different question to kick us off. I just read an article. I won't name the tabloid newspaper that I got it from, but it was about a woman who decided that at the time of us recording, it's Wimbledon. It's the 2 weeks of Wimbledon, the Wimbledon fortnight. She decided, I don't know why, just that she obviously clearly British. She wanted to go and queue for something. So she thought, I'm going to just queue for Wimbledon to see if it was worth it. So my question to you is there any event, be it sporting, music, film, etc., that you would queue for hours and hours and hours for?
I think I would queue for a Depeche Mode concert. And the reason is that last time they came over, it was at the O2, and I had a fabulous ticket, and I had a beautiful seat waiting for me, and there was an emergency in the department, and I couldn't go. And so my colleague was off sick, and I tried to offer it to a few people I knew who were much younger colleagues than me, and nobody wanted it. So unfortunately, the ticket was lost.
So this would be righting a wrong in your head if you could get this cue and this wish back.
Exactly.
I know for me, it would be, and regular listeners to the podcast will be rolling their eyes right now, it would be a Champions League final, Arsenal versus whoever. I would queue for hours and hours and hours to get in to see Arsenal in the Champions League final. But the less said about that, the better. Let's talk about this particular initial subject, which is an important one. And I think we're going to do it because this is a HR podcast with the lens of HR people listening into this. So can you start us off by just talking to us a little bit around why you think this topic of addiction is a challenge that HR teams need to be aware of, and what are the types of things they can be doing?
Well, over the years, I've seen many employees with substance use disorders suffer in silence and not accessing support or treatment. And for the ones who do ask for help, it's often very late after a lot of damage has been caused by their drug or alcohol use. So there is an obvious health and well-being issue here, but there are also other implications for employers in terms of risks, performance, and costs. Peter was using one of our NHS drugs treatment services. He started using heroin as a teenager, spent years in and out of treatment, and eventually, through medication, support groups, and sheer determination, he got into recovery. After a year sober, he was finally ready for something he never had, a job. But before his interview, Peter asked his support worker a question that says it all. Should I tell them about my past? He did not. He got the job. And years later, he's still there, thriving, valued, high-performing, but he's never been able to tell the truth about who he is. The shame, the stigma, the fear, it holds people back, and it holds employers back too. Because people in recovery bring resilience, grit, and problem-solving skills that you can't teach that easily. But if your culture doesn't make space for those conversations, you'll never see that talent walk through the door. In my opinion, from what I've seen, there have been a don't ask, don't tell culture going on for too long. And that's why after 10 years of advocating, I have decided to create a movement to look at it collectively through the HR lens, to open and normalize non-judgmental conversations about substance use and addictions in the workplace so that we can reduce the stigma and help both employees and employers to thrive.
I want to talk about the different sort of classifications, I guess, of addiction, but I just want to touch on that point that you just made, because I think it's quite an interesting one. Because the first thing that comes into my head is that piece around culture, and this example that you just said about Peter, because Peter obviously is somebody that has gone into a business that culturally perhaps isn't ready for that. How many businesses do you either speak to or think are ready to flip their culture? Because it's quite a big step, right? Isn't it? To effectively say, we know you have an addiction, but do you know what? That doesn't matter to us. And we'd rather just that psychological safety piece, I think is really, really difficult for a lot of businesses to take on. Like we can talk about psychological safety, can't we? Like everyone talks about, oh, are you psychologically safe at work? But that step to admit around the addiction side, that's like one of the biggest hurdles, right?
Absolutely. And it depends enormously from one organization to the other. I think some people will be more open to the idea of creating psychological safety, and they will be more welcoming addiction as a health condition rather than a disciplinary procedure, if you want, a misconduct, something like that. So we know substance use disorders have an impact on physical and mental health and well-being. There is a risk of overdose, A&E visits, more and more people are dying of alcohol-related liver disease. 1/3 of harmful and dependent drinkers also have depression. 8% of the death in our cohort of patients is by suicide. So there is a strong association between mental health and addiction. It is not always that blind, but that's not good news either. In my experience, HR leaders and other senior leaders fall into 3 categories. They are either unaware, scared, or they don't know how to tackle the problem of substance use and addiction in the workforce. So you have the first one, the unaware ones. They don't understand what addiction is or the extent of the problem. Then you have the scared senior leaders. They know if they don't do something, something bad might happen. But if they do something, they might open a can of worms. Senior leaders often avoid addressing substance use openly due to reputational concerns, assuming disclosure will cause liability rather than help. Hence why we end up with that don't ask, don't tell culture at the moment. And then you have the ones who don't know how to tackle the problem, or they generally believe EAPs are enough to tackle the issue. I think there are 3 reasons why addiction is a blind spot in workplace well-being. The first one, stigma. Stigma is a major barrier to accessing support. Addiction is still seen as a moral failing or misconduct, not a health condition. These days, mental health is discussed more openly, but addiction is not. Another reason is addiction is not seen as well-being compatible. Most corporate well-being efforts focus on stress, burnout, fitness, mindfulness, and all those topics are seen as safe and scalable. On the other hand, addiction feels complex, shameful, and risky. And another one, no metrics, no mandate. Unlike absenteeism or engagement, addiction isn't often measured in HR dashboards. If it's not tracked, it's not prioritized, even if the costs are massive. But how do you get the measurable data at the moment if we have a workplace culture where employees do not feel comfortable to talk openly about substance use and addictions and feel supported? They won't self-disclose, and you won't get the right data, and it's a vicious cycle.
Can I also ask you about that classification of addictions as well? Because I talked about it in my opening bit where I talked about everyone kind of assumes that addiction is, oh, it's drug abuse or it's alcohol abuse. But when we were talking prior to this, you even brought up things like, well, caffeine, for example. So can you talk a little bit around that side of it, just in the context of how people perhaps don't understand the levels of addictions and the impact that can have in the workplace?
Absolutely. This is such a, I think, essential point, Chris. So let's clarify the terminology, as I think it's confusing for many people. So substance use is not addictions. I like wine, I drink wine. We all use substances because if we don't, first of all, because we eat, and if we don't eat, we are dead. So see it as a spectrum. At one end of the spectrum, you have using with low risks of harm. And on the other end of the spectrum, you have addictions, which in a nutshell means continuing a behavior despite harmful consequences with a loss of control and compulsion. So for example, it's continuing drinking alcohol despite alcohol-related liver disease. It's continuing shopping, for example, despite having reached the credit limit on the 10 credit cards, etc. So when people who have addictions, when people say, why don't they just stop? Well, they don't just stop because if it was so easy, they would have done. Addiction is not a moral failure. It's a health condition. It's treatable. And we now have neuroimaging showing the changes in activity in the brain. Chris, if you would have told me when I smoked my first disgusting cigarette when I was young, that I would end up smoking 75 cigarettes a day for 11 years, I would have said, you must be joking. And by the way, I'm talking about substances like tobacco, alcohol, cocaine, painkillers, tranquilizers, and so on, for example. But the concept is also valid for what we call behavioral addictions like gambling, shopping, addiction to pornography or to screens, for example. So in fact, in your organization, so you have two cohorts of employees in your businesses. The first one, the employees with substance use disorders or addictions, and the other cohort, a much larger one, with many employees using substances. Most of them will not develop an addiction, but their pattern of use or habit might still be associated with risks, depending on where they are on that spectrum. For example, drinking 1 glass of wine 3 times a week carries different risks than drinking 12 glasses of wine a month in one go over 1 hour. So in terms of prevention for that large group of employees, don't focus exclusively on substances, but also on the reasons why people use. Do they use because they want to feel good, to self-medicate due to trauma or pain, to enhance performance due to social pressure, and so on? And make sure you educate all your staff so that they understand the associated risks and they know how and where to ask for help if they need in the future. Human beings use substances because they make them feel a certain way, and they've been doing that through history. I like to remind people that there was a big problem with nutmeg in the second half of the 18th century in England. So you're absolutely right. It's not just about caffeine. It could be any substance, and now we use nutmeg in our bechamel sauce or with mashed potato. But at the time they used 30 grams or 50 grams. And so it's a dissociative. So it was a bit the LSD of the time, I imagine. Yeah. And then people had seizures and they would even die on the streets. We need to understand the specifics so that we know how to treat them properly and how to prevent them properly, but also why people use them and what is the feeling they get when they use those substances.
Let's talk about how big this scale is, because you've just talked about nutmeg. I'm sure people there's not going to be HR teams checking the usage of nutmeg within the staff canteen is not going overboard here. And I'm not trying to trivialize it, but when we were talking previously, you used a really good example. But you had a conversation with a HRD who said that they have no addictions within their business. Can you just tell that story, just to give an example for showing that, sometimes the scale of this problem perhaps isn't recognized?
I started getting interested in substance use and addictions in the workforce in 2015 when I was working at a private detox center. And the first thing professionals said during the medical assessment was, please don't tell my employer, they think I'm on holiday. If they find out, I'll be fired. These were senior staff, lawyers, bankers, who all had access to EAPs and occupational health, but who didn't use the support available to them through their employer. So at the time, I thought I must make human resources leaders aware of the problem. They just don't know. And I managed to speak to the HR director of a large bank. And this is what he told me. We have no one using drugs or alcohol in our organization. At first, I thought he was joking. I thought, hasn't he seen the number of pubs per square foot in the city of London? Hasn't he seen the film Wall Street? But then I realized he was serious. And I thought, how are we going to tackle this? And shortly after, I spoke with another HR director in another bank. And she was lovely, and she said, "Oh, George, this is such a great topic, but unfortunately, if we tell the world we have employees using illicit substances, it's a PR disaster. So no, thank you very much." And we're almost 10 years later now, and little has changed, unfortunately. I was speaking to the HR director of a large company earlier this month. He told me they don't test because they don't want to know the results. So they don't test in the first place. He told me, imagine if our drivers can't drive our vans because they have to take time off work, then our business can't operate. So people are still scared of opening the Pandora's box, and we continue with the don't ask, don't tell workplace culture. But how much does it cost your organization currently versus facilitating access to support for your employees? The majority of treatment or support services are community-based, and it's highly unlikely that all your employees who need support will end up in residential treatment.
It's a challenging step, and I do actually understand the PR side of it, particularly if it's going to be looked at on a negative point of view. But some of the numbers that you gave me when we spoke previously around this is actually impacting bottom line, not addressing this. So there is like the cultural side of it, there is the societal element of it, like the don't ask, don't tell. But actually, yeah, give us some of the bottom line stuff of the impact that this has to organizations. I think that's a really, really good, important segue.
Brilliant. So let's start about the extent of the problem. So I've selected a few facts for your audience, not too many. £21 billion is the cost to UK employers from alcohol and drug-related harms. 40% of workplace accidents involve substances. 14 million sick days per year in the UK are caused by alcohol use. The challenge, you see, is that if you consider that around 70% of adults with a substance use disorder are in employment, that around 8% of the UK workforce has a substance use disorder, or significantly higher in certain sectors, then you'll be shocked to hear that only 15% of people with a substance use disorder receive treatment. So the workplace represents such a great opportunity to reduce the treatment gap. And yet, despite this, addiction remains taboo in the workplace. The stigma, the fear of disclosing, the fear of losing their job, they prevent employees from seeking support early. And this is also an EDI issue, by the way. Employees from marginalized or minoritized groups, including LGBTQ plus staff, women, neurodivergent employees, are more likely to face barriers to support, less likely to disclose, and more vulnerable to disciplinary action rather than compassion or intervention. So there are four facets we must consider if we want to change this. Substance use and addictions in the workforce is a well-being, safety, equity, and cost issue.
Yeah, really, really interesting. You've given some interesting stats there, 21 billion, 14 million sick days. So if you're listening into this and you're a chief people officer and you're thinking, have I got sick days within my business that are resulting in this? What is the answer? I feel like you've sort of given hints to it, but maybe I can just get you to give me more rounded views, because I kind of feel like one of the angles is measure it first. Because if you can measure it, you can then start to identify it. You can then answer the problem. So I want to get some thoughts around measuring it and what HR teams can do, just in your opinion. And then the second thing about that is it almost there's an element of, right, amnesty here, guys, time to declare this, and there'll be no repercussions for you if you do declare this as an employee. Like, what's your kind of thoughts around those two bits, the measuring it and the almost this kind of amnesty sort of approach?
Well, hopefully I've managed to show you that we know it's not that the problem doesn't exist, it's that it's not disclosed. There was a CIPD Managing Drug and Alcohol Misuse at Work report in 2020. They asked organizations who had disciplined an employee in the last 2 years how the most recent example came to their attention. And in just 7% of employers, the most recent example was disclosed by an employee themselves, just 7% of the cases. So you can see there is a long way to go before employees feel comfortable talking openly about their substance use or addictions. If they don't self-disclose, you will never know they have a problem. You can't measure it. So we are back to square one. It's the egg and chicken, isn't it? So creating psychological safety is essential. If people can't disclose, they won't disclose, and the employer, as the employer, you won't have the metrics you need, and it will keep costing you millions, while your employees suffer in silence. And that's another thing that's hardly ever talked about. Often they don't get appropriate support either, and it impacts on their performance and well-being too. So remember, the vast majority of people with an addiction look like you and I. So it might be your colleague sitting next to you. You might not know they are struggling, but you might also know they and be impacted by it. That's why we need to normalize open, non-judgmental conversations about substance use and addictions in the workplace so that everyone can access the support they need.
Can I ask you a quick question? Because you just mentioned it might not even be that person sat next to you at your desk. It might be they're impacted because a family member or something like that. What do you think is like HR's or even the employer's role in that, if it's a family member? Or is it just as simple as this is about people giving people the psychological safety to know that even if I'm experiencing difficult things through loved ones, and so it's not even related to me or my work is impacted, like what's HR or what are businesses' roles in that sort of instance, do you think?
I think the first thing would probably, it rings policies to me. So your workplace policies, how are they written? How are they welcoming those conversations? In fact, you should probably be, as an employer, you probably want to say something like, we know you use substances because human beings have done that all the time and they'll continue for a long time. We prefer to know than not to know because we value you, we value your colleagues, and we value the clients you interact with, our clients. And so as long as you engage in treatment or support, we will support you too, just like we would do with any other chronic health condition like asthma or diabetes. But I think it requires a lot of deep understanding about addiction. And of course, it's one of the most stigmatized health conditions through history. In the Middle Ages, they were burning people so that people wouldn't approach them. It's always been incredibly stigmatized. And people have that wrong, what's happening in the brain when you reach that level, that the habit you formed or the pattern of use created some form of harmful consequences. And you're at a point where you can't really stop that easily anymore. So if you take, for example, let's talk about cocaine because it's illicit and it's something that probably you don't hear a lot about, but you can really do the brain imaging of someone who's never touched cocaine, the person who started, and after a few months you do the same, and then after they stop, you see very different things on the brain. So before, it's with mental health in general, you don't have the hard tools. We didn't have the hard tools to evidence what we were talking about. If someone go to ski and they break their leg, you do an x-ray, you see it's broken, you do a surgery, and you see that afterwards it's not broken anymore, it's easy. We didn't have, and most of the time we don't have that in mental health. But with addiction now we start to have that evidence. So we need to consider it as a health condition that is treatable. So that's really that important bit. It's treatable. So the same CIPD report I mentioned from 2020, they show that if you send people to treatment, I think it was 22% of employers said that they had referred someone to treatment services or specialized support. So it might sound like quite little, which is true, it's not a lot, 22%, but that's not my main worry. My main worry is that the people I see arriving in our services, and I've seen that for years and years, that they arrive so late. So if you have an ear infection, for example, you don't wait until you can't hear anymore 5 years later to go to your GP, get the ear drops and all sorted after 2 weeks. You don't wait that long. So I think here people wait because they don't want to disclose, they are ashamed, they are embarrassed, they have the self-stigma, the internalized stigma on top of the stigma from the general population or in the media. And I think the media have a big role to play in that. And there is something, but you need to be open to the idea as an HR person or as a senior leader. You need to be open to the idea that actually it costs us more. Ignoring the issue is worth than addressing it. And I think we are really at that point for a long time now. So time someone tries something that will make a difference.
But one of the things I do want to talk about, because if you're listening into, I think lots of organizations will say things like, well, we have an employee assistance program, we have an EAP approach. So, we're kind of doing our bit. You've got some very interesting views on that. I wouldn't mind you sharing with the audience if that's all right, because that kind of, is it a bit of a tick box exercise to say, well, we have this over here, so we're kind of dealing with the problem through our EAP? What's your kind of view on EAPs and their approach? And I guess you can do pros and cons if you want.
So if I disappear mysteriously after this show, please tell the investigators what I said about EAPs. But I'm a doctor, so it's all about evidence, and research shows that, in a nutshell, EAPs for drugs and alcohol, they don't work. They may well work for other things, but not for substance use disorder. There is no consistent evidence that EAPs are associated with a reduction in substance use. The four major issues I can see with EAPs are they are not enough, not the right expertise, not the right measures, and not preventive enough. So they are not enough. I keep hearing people complain that EAPs are not utilized enough for all sorts of reasons. Only a small percentage of employees use the services, but that's not what I worry about. I know that even if they were used by 100% of the employees living with addictions who need help, they would still not be providing enough support by design. EAPs are usually designed around time-limited counseling model, 4 to 6 sessions. The model is by nature inadequate for chronic relapsing conditions like addiction, which often requires ongoing care, treatment pathways, and long-term support. So EAPs are better than nothing, don't get me wrong, but it's a bit like giving one chickpea to someone who is starving. That's not enough. The second major issue I can see is that they do not provide the right expertise. Most EAPs are staffed by generalist counselors or therapists, not addiction specialists. As I say, addiction is a complex medical and psychological condition that requires specialized training to assess, treat, and manage. And it's not the scope of standard EAP provision. So generic counseling is not enough to address the complex nature of substance use disorders that requires specialized training. The third thing, they don't provide the right measures, both in terms of interventions and in terms of metrics they collect. And there is a wide range of interventions offered by various EAP providers, but what is actually effective? What works? Does your EAP integrate with clinical pathways and specialist services? And how do you measure the success of your interventions? If your KPI is simply being recommended by clients, that doesn't interest me that much. Having an EAP for addiction without the right interventions and metrics is like going to a travel agent and buying a package holiday to the Maldives. EAPs are mainly reactive. They often intervene after performance has suffered or after disciplinary proceedings have started. They don't address workplace culture, stigma, or policies that may deter employees from coming forward, and they are not tackling the substance use or addiction issues in the broader workforce. We never know if and when someone is going to develop a substance use disorder or an addiction. So we need a tool that is able to support both groups, support the 10% of your workforce living with addictions to quickly access appropriate treatment or support, as well as supporting the remaining 90% of your workforce with prevention. And for those, it's like having safety belts in a car. You might never need them, but if there is an accident, you are happy you got them.
That's a really good endpoint, actually, for today's podcast. And it's really interesting that you've talked about that. I know you made a comment about EAPs and your thoughts about them, but I think it is important to note that you can't just sort of sticking plaster something like this. And one of the underlying messages I certainly take away from our chat today is this idea of the prevention side. And that prevention side comes through potentially culturally looking at yourself as an organization. Like, are we prepared to ask ourselves awkward and perhaps socially uncomfortable questions about addiction within a workforce, our workforce, whatever it is? I think there's an element of cultures in really embracing true psychological safety side that you've talked about as well. I think there's also education piece around what addiction is, because as you talked about the nutmeg analogy, the caffeine side, like this isn't just, these people that drink 30 pints of beer every single day or every single week and are going on long lunches and coming back drunk and they're not very productive, or this is people that are doing substance abuse. This is recognizing the different balance levels and as an organization, there's an element around understanding at what point do we need to get involved from a HR perspective as well.
There are a few things I think, because I remember your podcast says it's about actionable strategies as well. So in terms of EVP, I think one of the things you could integrate addiction into your well-being and EDI strategy. So stop making it a siloed risk under HR or compliance. Treat it as part of your mental health, well-being, and equity commitments. The second thing, make help visible and safe to access. Use inclusive language in your policies and everywhere. Avoid managers using words like addict, alcoholic, junkie, stony, druggie, drug abusers and so on. Share stories of recovery, make sure you communicate confidential referral options clearly and regularly, and make sure it's culturally normal to ask for help early, not just at crisis point. Educate managers and staff alike. Most people only know about addiction through media or anecdotes. So bring in evidence-based training so people understand the spectrum of substance use I mentioned earlier and the path to support. And then finally, audit probably your EVP through that lens. If addiction is ignored, your EVP has a blind spot. So ask yourself this question. If someone on our team needed help with addiction, would they know where to go? And would they trust us to help? So if you can answer a big yes to, then it means you've done incredible work.
George, thank you very much for joining me today.
Oh, my pleasure. And if people want to contact me on LinkedIn, they can go on Dr. George Petitjean and connect with me if they want, or ask me a question. I'm always happy to speak with people.
Brilliant. And what we will do is in the show notes, and then also we'll tag the podcast so that they can reach out to you as well. But hopefully you've enjoyed this podcast as much as I've enjoyed recording it. It's been really, really fascinating to delve into, as I said, right at the top of the podcast, what can be viewed as a bit of a taboo subject. But actually, hopefully it gives some food for thought to asking some questions. And George gave some really, really good wrap-up questions that you can take away from it as well. But from myself, from George, thank you very much for listening. And we'll catch you next time on the HR on the Offensive Podcast. Bye-bye.